Well, welcome everybody. Listen, I know that all of you went into medicine for different reasons and you like different things about OBGYN, and ultimately your career choices from here on out will also be based on those interests. But I'm hoping that the reason all of you are here this morning, especially the faculty and the residents, why you're here this morning is because you would love to teach and you want teaching to be a component of what you do. Hopefully those of you who are interviewing here for our program also feel that way, because we're very much a teaching program, and there are residencies where that is not a focus of the program. So hopefully that's the topic and the theme that will bind us together this morning as we go through this talk. As Dr. Forstein has said, I don't have any disclosures related to the content of this presentation. I do have some learning objectives, but to be honest with you, these are not so important. This is my way of kind of doing faculty development with all of you. We don't have a formal way to do that yet, so I'm going to use this morning to just teach you a little bit of what I know and what I'm passionate about. So this morning, we're going to talk about quality. You know, you hear that word a lot now in medicine, don't you? We talk about improving quality of patient care. Well, this morning we're going to be talking about improving the quality of what we do as teachers. And so in order for us to just talk about quality, I wanted us to just think about how we define quality in different careers. I'm going to try to make this interactive for us this morning. So when you think about someone who is an actor, how do you define a quality actor? What are the ways you measure that?
Oscars.
Awards, Oscars. Any other ways you'd measure it? How cute they are? Okay. I suppose you have a measurement for that. All right. So maybe also box office receipts. That's really important to the movie houses, right? How about athletes? How do we measure a quality athlete? Yeah, that's good. So games won, records set. And I'm a Packer fan, so when Brett Favre was a quarterback there, he set a lot of records, and that's a distinction for him. How about lawyers?
Yeah.
What's that? If they're shady. That's not how we define a quality lawyer. All right. So cases won, settlement amounts. Isn't that how John Edwards, made his name for himself? Right? He's beloved by OBGYNs. So now let's get to the heart of this. How do we define teaching quality? Think about it. How do we define that? Think about great teachers you've had. How students do on testing. Okay.
What you actually take away. What you actually remember.
What you remember. What are some of the things you remember about great teachers?
Ability to motivate.
That's a great one. Any? What's that?
Passion for teaching.
Passion. Great. Great. So those are all great ways for us to think about teaching quality. Well, what I want to talk to you guys a little bit about is how in academics, actually outside of medicine, but in the larger undergraduate community and colleges and universities, how people think about teaching quality, and especially faculty performance. And this is a survey, and I'll quote several things from Peter Selden in this talk, but this is a survey that he did in 1999, and he surveyed liberal arts colleges throughout the country, a sample size of almost 600 schools. And he asked them, what are the factors that you use in determining faculty performance? Well, just like each of us as faculty, there's many different ways that we might be measured in terms of the things we do other than patient care. Same thing is true for college and university professors. But you can see far and away, the one thing that was very important, regardless of the type of school, was how a teacher performed in the classroom. And everything else wasn't even close. So there's an emergency medicine physician named Rob Rogers. He's at the University of Maryland. And he put this all together in the context of clinical teaching. And he said, what are the things that really matter when we think about clinical teachers? The first T stands for just being a teacher. I was like, gosh, that's so redundant. What does that mean? Well, a great teacher is someone who actually understands the process of teaching, and they apply specific skills to engage the learner and make it a good interaction for them. A great teacher is also something someone here mentioned, someone who's enthusiastic about that role, who's just not approaching it like, oh, I have another student here on L&D today, but instead saying, I'm really enthusiastic about it, and let's see how we can engage this person in what we're doing. A great teacher also provides appropriate feedback. Now, if you're like me, this is a hard one to do. Positive feedback is very easy to give, isn't it? But it's the more formative and constructive feedback that's harder to give, and it has to be very timely and in a safe environment for it to be effective. A great teacher is also centered on the learner. Now, a lot of us especially at the faculty level, we kind of get into a groove and we're taking care of patients and we're thinking way up at this level, and we may actually forget that this person with us is not anywhere near the level we are. And we have to refocus and say, how can I explain these things at a level that this person would understand? A great teacher is also someone who's helpful. And what does that mean? Well, it means that you actually teach things that are relevant to that person that you're with and not things that are very obscure. And a great teacher always tries to elevate the learner to independence. That's what being in medical school and residency is all about. It's being able to practice medicine independently at the end of that gauntlet. And a great teacher recognizes that. And it's a lot about not just telling someone the what, asking them the what questions, but it's asking them the why, because that really challenges them to apply their knowledge. And a great teacher, lastly, has to be a great role model. Think about it. We naturally gravitate to the people that we can see ourselves being like in the future. Either they're great in the OR, they're great with patients, they're very engaging. We see ourselves wanting to be like that person, so we're going to gravitate towards great role models who have those attributes. So, we get to the point then, if we say that all of these components are what makes someone a great teacher, how do we actually measure that? How do we measure teaching quality? I want you guys to think about what your experiences have been. How do we measure your teaching in the Department of OBGYN?
Get a handout
You get a handout?
with little medical student ratings.
Okay.
What was that?
What's that?
It had a lot of the components of the teacher scale.
Yeah. So student ratings, that's certainly one way to do it. If we go back to the study that Peter Selden did, he actually compared what has happened over time. And he looked at a similar survey that was done of measures of teaching quality of faculty at universities from 1978, and he compared it to his data in 1998. And we can see some trends here across time. We can see that in 78, the predominant way that universities assess teaching quality was by what they call administrative review. That would be like your dean or your chairman kind of looking at your portfolio of work and saying, do I think this is good or not? But we see some trends across time over the next 20 years, and what do we see? We see a marked increase in exactly what someone said, in that learner ratings become the predominant way to measure teaching quality. But we also see a balancing out, and we see an increase in the use of some of these other things across those 20 years. So when we look overall at the spectrum of measuring teaching quality, there are several different ways that we can approach this if we look at that collegiate model. There's learner ratings, administrative review, peer review, learner outcomes, and what I'll call other. And what we're going to do is we're going to spend the rest of our time together talking about each of these. So let's start off with learner ratings, because I think that's something that we're very familiar with. So I gave you all a handout when you came in, and I don't know if you had a chance to look at that. But that handout kind of summarizes, I think, the way we think about a lot of these learner ratings. I think some of you have already started or maybe perhaps finished your Christmas shopping, and if you bought a gadget, I have no doubt you probably went to a website and looked at the reviews or ratings of that gadget to figure out which was the best one to get, right? We're very much in that kind of consumer and customer satisfaction era in our country's history. This is also, unfortunately, very true of teaching. And I hate to break your bubble, but this website actually exists. I don't know how many of you have ever seen this before. RateMyProfessor.com. So they have a catalog of every accredited university, every professor that teaches at that university, and you can go to that website, you can find your professor, and you can, in fact, submit a rating. And I've pulled the rating up from my friend Kurt Horn. He's a professor at North Greenville University. Let's look at the components of the rating here. Overall quality, helpfulness, clarity, easiness, there's even hotness. They get a chili pepper if they're good looking. Didn't someone say that? They were right on, right? So good looking can be a component of ratings. This is on the web for anyone to go and see. And believe me, this school will very soon end up on ratemyprofessors.com. And you, all you faculty, can go and look at your ratings, available to the general public. Well, how do you think that makes you feel as a faculty? You know, the faculty want to strike back too, right? So there have been many times when faculty, out of angst, have tried to rate their students. And you can go to this website, it's no longer active, but you can read through these posts about students, and they're just hilarious. So faculty really have a very negative impression many times about learner ratings. They think that they're not valid, and they really don't like the fact that they're judged by them. And I think maybe some of your residents, sometimes you get a rating and you're like, I can't believe they said that about me. Well, believe it or not, learner ratings actually are the most validated form of evaluating teaching that there is. And people have looked at all different kinds of biases regarding learner ratings, and they've proven them through a lot of literature to be wrong. And I want to point out to you 5 specific myths about learner ratings. I can't go through all the literature on this, but I'll tell you, but all of these myths have been refuted. Number 1, a lot of people think that students cannot make consistent judgments, and therefore learner ratings are false. And this has been refuted. Only excellent researchers can judge teaching because research and teaching are linked. This is false. Even the most novice learner is able to accurately assess teaching quality. Another myth, student ratings are only popularity contests. How many of you think that, have thought that before? I have. Not true. Student ratings don't correlate just with popularity. They actually correlate with different domains of teaching. Number 4, ratings are biased by the gender of the student and instructor. I remember thinking that as a student when I was getting evaluated by some residents and faculty. In fact, that isn't borne out. And the last myth that we should kind of purge from our memory is that grades bias student ratings. I know a lot of people think that. And they think because I rated this student this way, I gave them this kind of feedback or clinical grade, they're now going to give me a bad rating. And I've had that discussion with many people. The bulk of literature says that that's not true. So now that we have those myths out of the way, I think we should ask the question, what should be the content of a clinical teaching rating? And you guys kind of have some experience with what we use here. Well, there's a nice study done by Beckman, and they actually asked the question of how reliable are assessments of clinical teaching. And this was published in 2004. They did a literature search to identify published instruments for assessing teacher clinical teaching. And they found several instruments, there were about 21 in this study, and they identified 14 domains that were mapped out of all of these 21 ratings. And they also looked more specifically about the reliability of these rating scales. Now, for example, this is a rating scale that you guys got this morning to rate me. I doubt this has been validated regarding its reliability. And so that's what they were looking at, the types of validation that occurred. When they looked at these 21 forms, they found some problems. And here's what they found. They found that sometimes people were using one specific type of rating form in various venues. They were using forms both in inpatient and outpatient setting, and we know that the approach to teaching in both of those areas can be very different. They were also trying to use one form for a diverse array of learners. The way a medical student, a resident, and a fellow respond to a teaching intervention is going to be very different because their expectations are going to be different, and you have to use a different approach at each level. Most concerningly, they found that there was really a limited scope of validation for all of these forms. A lot of people hadn't made sure that the content mapped to exactly the question that was being asked. So there is a lot of use of student ratings, but not necessarily are all the forms that are being used appropriately. You guys are familiar with the reports that you get back from us as far as your student ratings. I want to assure you that that is a validated instrument. We got that from the Medical College of Wisconsin and went through a very rigorous validation process, and we use that form now at our institution. And it addresses all of these issues here. We have questions that are very specific both to inpatient and outpatient settings, even though it's one form. It's only used at the medical student level, and it has been rigorously validated. So let's look at the next form of measuring teaching quality, which is administrator review. And this is something that can involve multiple components. Usually it's someone like a chairman or a dean looking at your compendium of materials, maybe a portfolio, and reviewing them. But a lot of times it can also involve direct observation, so them watching you actually perform the teaching in real life. Now, this is something that is very often used at a college, university level, but very rarely used in the medical education setting, at least in the clinical setting. But there actually was a study that I want to bring to your attention, and this was done by my friend Nadine Katz, who's at the Albert Einstein College of Medicine. And here's what she did. She wanted to plan a teaching intervention to help residents very specifically with teaching skills, but she didn't really know where their deficits were. So they designed this 18-item checklist of teaching skills, and they went into an outpatient clinic setting and they observed several residents in the act of teaching over time. And here's what they found. The actual teaching behaviors that they were looking at, you could break into these 5 categories. I know this might be hard to see. They had 54 observations, but the areas where the residents struggled the most are the ones highlighted here. In the introductions, orienting student to clinic, orienting staff to student's role, and then in the lower part there, focused teaching agenda, identifies what students should learn, and then again at the very bottom, the feedback. I bet if you think about the things that maybe you don't do as well, they might be exactly these types of things. So this kind of approach, administrative review through direct observation of teaching behavior, can be very helpful in identifying your capabilities as a teacher. So let's move on then to this issue of peer review. And I want to ask you guys a question. You're all very familiar with the process of peer review. Those of you who've written papers or created different things and submitted them for review, you know how that works. And I'm assuming that you believe that that's a good process and very necessary to validate the quality of someone's work. But I think we should ask the question, should peer review be applied to teaching? What do you guys think? Does it make sense?
Why not?
Why not? Okay. Anyone have any other ideas?
Maybe some conflicts of interest, because you may be trying to see what the other guy's doing or outdo the other guy. There may be some conflicts with peer review.
Yeah, definitely. Can you think of other concerns regarding peer review?
How much actual time can we see each other? I mean, we're all doing our own little things. I don't know how great it is at
Yeah.
the time.
You haven't seen his teaching evaluations. So that's right. So it's an issue of time and resource too, isn't it? So we potentially have a conflict of interest, and you don't want that guy to get the promotion, so you're going to go do his peer review and mark him down. You don't have enough time. You have too many cases scheduled, too many clinical responsibilities. There certainly can be a lot of reasons to make peer review difficult. You'd be surprised, though. A lot of you are saying, Dr. Forstein, for example, is saying, why not? But you'd be surprised. In the history of education, peer review actually is a very recent idea to be applied to evaluating teaching. And it goes back to the fact that in traditional academic settings, the main activity that was considered to be scholarly was just doing research. And even though we saw that in that university survey that people looked at the quality of teaching, the way people were actually rewarded for their work is by the number of publications that they had. And that was the traditional approach in academic universities. Well, it wasn't until Ernest Boyer published his thesis, Scholarship Reconsidered, that we came to understand that scholarship actually should have a broader view. And what Boyer did in this document is he defined 4 domains of scholarship. Now, the first one you'd be very familiar with, and that's what he called the scholarship of discovery. And this would be very traditional hypothesis or research question-driven research. But the next type of scholarship that he defined is what he called integration. And that's putting discovery into a larger context. So that's synthesis. So someone made this novel observation or discovery, but what the heck does that mean? And how can it be put into the greater body of literature? You can sequence the whole human genome, but if you find one aberration, what does that mean? And that's what the scholarship of integration is all about, defining more clearly what that one thing is. And then there's the scholarship of application. And this is what we see a lot in technology. So someone will invent a new way to create a display or a new way to send radio signals, but then someone else has to come up with a way to make that useful, to put it to use. And that's what we call the scholarship of application. And finally, Boyer said there's definitely also a scholarship of teaching, because teaching involves taking all of these things, discovery, integration, and application, and then transmitting that knowledge so that others might begin to synthesize it, use it, and then in essence generate more discovery. So right now you might be saying, oh, that makes so much sense, that's so obvious. But not till 1990 did it really start to sink in that we needed to think more broadly about the activity of teaching. Well, once we accept these definitions and say, you know what, we do need to look more broadly at what people do as far as scholarship, there then also has to be a way of assessing scholarship. There has to be a way of saying that regardless of the type of scholarship that someone's doing, that we can make sure that it's quality. So in a follow-up work by Glassick, also by the Carnegie Foundation, they define several ways that we can assess scholarship, and they include setting clear goals, involving adequate preparation, appropriate methods, significant results, effective presentation, and reflective critique. So regardless of which type of scholarship you're generating, you should be able to assess it using in each of these domains. But more specifically, Schulman, who was the president of the Carnegie Foundation, later said, if we really want to assess the scholarship of teaching, because it's so different in its content from the other types of scholarship, it must meet this type of criteria to be considered scholarship. So the work must be made public so people can review it, so they can also do integration or application with it. And the work must be available for peer review and critique according to accepted standards. And so that's the real impetus then for us to say if we're going to call teaching scholarship, it must be amenable to peer review. And he also said the work must be able to be reproduced and built on by other scholars. And this is kind of the rationale for why you as faculty are being challenged by Dr. Wiper to take your teaching and convert it into a tool like a Pearlcast that then can be assessed for its scholarly content. So what effect did this have, Boyer and Glassick's reports have on the way universities approach the scholarship of teaching? You can see as far as this survey goes, in terms of measuring teaching quality, we see a marked increase in the use of peer review for assessing teaching at liberal arts universities in this time frame. So now here's the tougher question. We can say that all makes sense, it's great in theory, but how can we practically apply peer review in the clinical setting? I think some of you have already brought up some concerns about how difficult that might be when it comes to clinical teaching. Well, you'd be right. There's been very few descriptions of people using peer review in the clinical setting. And this study by Beckman is one of the few examples that you'll find in the medical literature. What they did was, in the 80s, there was a Stanford faculty development program that was developed, and it included 7 core domains of teaching. And they had a 28-item instrument that they developed from that could be used to rate, for students to rate faculty. So at the Mayo Clinic, what they did was they modified that for the use in this setting of peer review. And what they did was they went then and they had peer reviewers who were faculty who went and on rounds on their general internal medicine service. Now you can see they had 10 faculty observed for 100 hours. So they spend a lot more time rounding than we do in OBGYN. And at each instance, each person was then rated by 3 faculty peer reviewers. Well, what did they find? When they used this peer review instrument, they found that of those 7 Stanford faculty development program domains, learning climate, communication of goals, evaluation, and self-directed learning had great internal consistency. That means from reviewer to reviewer, they were very consistent in the way they evaluated in those domains. Unfortunately, they had poor rater consistency in these other 3 things: control of session, understanding and retention, and feedback. So it brings up the question, why would that be? And why would we have problems in one area and not in the other? Well, there are several keys to peer review, and that's summarized here in this article by Desir. Whenever we attempt to do peer review, we have to have very consistent definitions. And what they found was the reason those other three areas were not being evaluated consistently is because the reviewers had different ideas about what those questions meant, what those rating scales meant. And it's very important to use a validated instrument. Although you'd say the SFDP was validated, this Mayo instrument wasn't, and that's how they were able to identify there were inconsistencies. If you're going to use a peer review system, you have to train your reviewers. You can't just send me into the room and say, evaluate how Dr. Garris is teaching today on rounds without giving me very specific training about what I'm supposed to be looking for and how I'm supposed to be using the rating instrument. And there has to be clear definitions of how data will be used. This is really important to the person who is being evaluated, because if they don't trust the process, then it will definitely skew the results. And there has to be consistent application. Again, that goes back to having a set agenda, making sure the person understands how that data will be used. But one of the neat things about peer review, I know it's difficult, we're saying it's difficult to do. One of the neat things about it is that it's an instructive format, not only for the person who's being reviewed, but it's also instructive for the person who's doing the review, because they get to observe and see how people conduct themselves. And oftentimes you can see in that mirror of someone else the things that you do effectively or ineffectively. So it's a great tool, but certainly has some limitations. Well, the next type of teaching quality metric that I want us to talk about is learner outcomes. And I actually think someone said this. I think, Saritha, you mentioned that this would be a way to define teaching quality. And this is really important, because a lot of times we believe that it's just important to look at the activity of teaching and say that guy is teaching well. He's got a good set of slides, the learning objectives make sense, the syllabus makes sense, but we almost act like it's a void and disregard what the actual outcomes are regarding the learner. Now, you remember we had this election just recently, but one of the big things that came up right before the election was the Chicago teacher strike, and I'm sure you remember that. I don't know how many of you realized it, but the key issue in this strike was actually how they would use learner outcomes in teacher compensation. Well, this actually is not a new issue, even though it's 2012. This issue first came up in Los Angeles in their school department. And this has actually been an initiative of the federal government, Department of Education. And they want very much for schools that get federal funding to link compensation to learner outcomes. What happened in Los Angeles is student performance on standardized tests is actually in the public domain. So the LA Times had figured out that they could get that data, and what they did was they did what's called a value-added analysis. And so they looked at the performance of specific children in the school system, and they anchored their performance on their initial test and used that to predict what they thought the natural progression would be for that student who performed at that level on their first assessment. Any excess in performance that occurred on the next testing, they said, was value added by the job of the teacher. And what they found was, in that analysis, was that there were very specific patterns. And regardless of what the baseline test score was for a student, that certain specific teachers always had much greater performance for that student if they were exposed to that student on a subsequent performance. And the LA Times then went and they posted this on their website, and parents could go and actually search a teacher and see what that teacher's value-added performance was. Of course, caused a huge uproar, but now they have a value-added system for teacher compensation in California. So this is something that seems to make sense, and there seems to be data to support it, at least in the secondary educational system. But there's actually very good correlation between learner ratings and outcomes even in the clinical setting. And so if we look at how students rate the teachers that they're exposed to and correlate it back to measures of outcomes like OSCE performance, NBME performance, we see there's a very strong correlation. Students who rate their teachers very highly have a better performance on these assessments, and vice versa. We also see that resident teachers have a stronger influence than faculty in clinical problem solving. And what that means is students identify far more with you in terms of the things they're trying to learn than they do with what the faculty do. Because the faculty tend to operate at a much higher cognitive level, and they kind of skip all the in-betweens and don't explain them to the students. Unfortunately, this correlation between learner ratings and outcomes is much stronger for poor ratings. So the effect is far greater. If a student has rated their teacher very poorly, that student is going to have a far worse performance than those that rate their teacher positively. So now we get to the last part here I want to talk to you guys about, and that is the other, and something that's very specific to medicine. There is something called an objective structured teaching exercise. How many of you have ever heard of that before? Yeah, great. So this is very similar to what you guys who are still in medical school would have done as far as taking an OSCE, and I'm sure many of you have taken OSCEs in the last couple of years. The difference is, instead of the learner being the one that's being tested, the teacher is the one that's being tested. And it's set up so that there's a standardized scenario and there's actually a standardized learner. And that learner is acting, and then it's the teacher, either the resident or the faculty, who's being assessed in their performance. And their OSCEs can be developed for all kinds of these different learning interactions. So we actually did a study here a couple of years ago, and Jill Lee, are you here? Is she here? Nice. Okay. Well, Jill Lee is the resident who did this study with me. And what we did is we asked the question, you know, medical students love to do vaginal deliveries, but how well do we teach them? And if we try to do something, if we try to train our residents to more effectively teach them through the use of an OSCE, will that have an impact in their performance? So we set up this quasi-experimental study, and the first year we took a normal delivery and we broke it up into 16 component steps. And we said these are pre-delivery steps, these are delivery steps, and these are, you know, post-baby delivery steps. And we had medical students who came through our clerkship rate their level of involvement for all of those steps. Then we did an OSCE with all of our residents. We ran them through a standardized scenario with a standardized student, and then we gave them feedback on their performance. And after that, for the next year, we had the students do the same thing. And this is how they rated each of those components of the test, those 16 steps of the vaginal delivery. The goal was to get them more towards the performed independently score. So that would be a higher score on the Likert type scale. Well, this is something, we found something very interesting. When we looked at the first year's data before we did the OSCE intervention with the residents, what we found very unexpectedly is one of the lowest areas of involvement for the students was in the pre-delivery phases, in the part where they're not even touching a patient. We weren't engaging them in those things. So when we did the OSCE, we made that a very specific area of focus, and we told our residents, look, this is a great teaching opportunity. It costs you nothing. You can still do the delivery, so you don't have to feel like you're giving it away to the student, but it'll really impact their learning. Now, an interesting thing also happened between the first year of the study and the second year, and that is that we started getting a lot more learners up on labor and delivery in the second year of the study. So the actual number of deliveries available for learning for our students dropped off significantly, almost by a quarter. Well, let's see what happened. If we focus just on these pre-delivery steps, the 2 steps of setting up the delivery table in an organized way, prepping the instruments, and draping the patients, we see despite a 25% reduction in the number of deliveries experienced by the student, we saw a significant increase in the level of involvement for those students in those steps following doing the OSCE with the residents. So you guys did a great job, and I commend you on that. You took advantage of the teaching and you made it work for the student. So here we go. We've gone through all of these different ways to measure teaching quality. So the last thing I want to talk to you about is we have all of these great tools, right? We should ask ourselves the question, which ones make the most sense for us to use in a clinical teaching environment? More importantly, what's the best way to use them? And I think the key question we should be asking then is, what is the difference between evaluation and assessment? Who wants to tackle that? We see these words all the time, don't we? What's the difference?
One thing of evaluation is a retrospective type review as an assessment, whereas a provocative testing methodology.
Oh, very good. Anyone have other ideas?
To me, evaluation measures an endpoint, and assessment to me applies a systematic review from beginning to end to arrive at an endpoint.
Leave it to Dr. Gailey again. Well, you know, whenever I have a question about all these fancy words, the first place I look is actually the LCME standards. And here's what they say, and I actually don't find this too helpful. It says the use of the terms assess and assessment is consistently reserved for description of activities related to the assessment of medical student performance, while the use of the terms evaluate and evaluation is consistently reserved for faculty, resident, course, and clerkship rotation, and program evaluation. That makes no sense to me, right? So there must be something about this. When you guys who are students are saying that we should assess you, well, why would that be? Well, maybe it's because when you're going through your 4 years, you are being assessed. And the final decision about whether or not you're competent to get an MD degree doesn't come till the end of the 4 years. It's a continuum. And that makes sense with what Dr. Gailey's talking about. But don't you think that's a little bit biased? Why should teachers be evaluated and students be assessed? Does that mean that teachers are a finished product the first day that they come onto faculty? They already have all the teaching skills that they need? I mean, I didn't, and I'm still learning. I'm still trying to get better in this regard. Well, if we actually look at people who have thought about this more clearly than the LCME, there is a difference in evaluation and assessment. So if we look at evaluation, as Dr. Gailey said, again, it's something that's summative. It's final to gauge the quality. The focus of the measurement is product-oriented. It's saying, what have you learned? So this should be, you're evaluated before they give you your diploma in May, right? And the findings, they're judgmental. You arrive at an overall grade or score, okay? How about assessment? It's formative. It's ongoing to improve learning. It's process-oriented, how learning is going, and it's diagnostic. You identify areas for improvement. So when you think about your role as a teacher, which one would you like? Would you like to be evaluated or would you like to be assessed? Yeah, assessed. So let's look at what the outcome is, because unfortunately, in most places, and including here previously, we had very much an evaluation approach to assessment. To teacher evaluation. So this is how it worked. We'd collect learner ratings throughout the year. Students would come through on the clerkship, we'd accumulate all of that information, and then at the end of the year, it would be given to you. And for those faculty, you would go and meet with the chairman, and he'd say, well, look, this is how you're doing how you did on your teaching this past year, and this is how much weight I'm going to give it. I am or I am not going to reward you for how well you were a teacher. That's really not great, because I'm guessing if that happened to you, you would have said, boy, I wish someone had told me about this maybe in the first part of the year so I could have done something about it rather than hearing about it at the very end. What would an assessment approach look like? Well, here's a potential example. You could get learner ratings, and every time you get your rating, that information is immediately given to you. You could also add in other ways to assess your teaching skills, like an administrative review or an OSTE, and combine all of those things together and give it to you in a timely manner so that you would have time to improve what you're doing. So that would result then at the end of the year for it being very low stakes for you, because you would already have had an idea throughout the year where you were headed. You would have time to remediate, and then at the end of the year, it wouldn't be a big surprise as to what the outcome would be. Now, the reality is, for most places, learner ratings are still the only way people's teaching is determined. The quality of their teaching is determined. So I think it's an important question for us to ask, how can we maximize the value of learner ratings? Now, Dr. Wiper just showed up, and a word that he often uses, a word he often uses is transparency. He says we should be very transparent. Nothing about you without you. It's something that he taught me the first couple of weeks he was here. Well, someone tried this approach, actually, in regards to learner ratings. And my friend Dee at the University of Tennessee published this study. And so they have an 8-week clerkship, and they would use a rating form on the clerkship for teaching evaluation data. They tabulate it after each block. Now, UT Memphis has a big clerkship, so there wasn't an issue as far as blinding and maintaining anonymity. But what they did was that individual data was disseminated without blinding to all faculty. So every single person's teaching evaluations was sent to every single person. How would you all feel about that? Can we do it here? Would you like that?
No.
No? Why not?
Well, because I think that evaluation and feedback is personal, and that makes it a personnel issue, and we don't treat any other personnel issues publicly.
Okay, so it's a...
I think we read each other's as preceptors.
Oh, don't give it away.
Ours are all exposed,
Yeah.
transparent.
Well, what do you think happened with this approach? What would your guess be? How did this affect the environment?
I think it more competitive.
You think it made it more competitive?
I think it could be.
It makes you better. I think it has made us better, hasn't it?
You know what? This is what happened. So Dee said almost immediately they had a marked increase in the teaching ratings, especially, of course, from those lowest performance. They bucked up. They were like, I don't want this. I don't want to be embarrassed. But in the long term, it had no sustained effect. They just regressed back to what they had been doing. They accommodated. They got used to the idea of people knowing the shell game they were running, right? And so it didn't matter to them anymore. There was no additional incentive for them to continue improving in their teaching. So it seems like transparency is a great idea, but by itself, it's not going to produce a sustained result because people will become comfortable with transparency and then just keep doing what they're doing. So there is an alternative, and that's called peer consultation for learner ratings. And this can be used often in lieu of peer review because we've said that that's often very difficult and time-consuming. And what you do is then you pair faculty into peer groups and you give them this information. For example, you could use learner ratings and you have them review and discuss it and you develop improvement goals. So David's a great lecturer and Chip is, I think, the best lecturer in the department. He gets the best ratings in that domain. So one day I went by and I watched him lecture to get feedback, but it would be even better if I would have him look at my evaluation and say, Chip, give me feedback because that's an area where I don't do well. And that would be a peer consultation. And learning occurs for both parties because in that dialogue, we're able to learn from each other. And Dr. Demosthenes is exactly right. 2 years ago, we started doing that with our preceptors, our community-based preceptors. We made a peer consultative group. We sent them all each other's evaluations. We met together for a preceptor retreat, and we went through every single domain of the evaluation. And we said, look, Lauren, you're great in this domain. Do you have any tips for those of us who aren't as good? And each of us went around the table and shared that kind of information with each other. There were a couple of preceptors that had some areas that were low performing. They had a marked increase in their scores by the next assessment. So this really does work. And now we've had sustained high ratings because we've continued to do this peer consultative approach with our preceptors. And this is actually something that I'd love to see happen more globally in our department with our residents and our faculty. I think it could be something that avoids the concerns that Dr. Forstein has raised and puts them into a more positive perspective. So there we go. We have all of these different ways of measuring teaching quality. And you might not think it, but we've actually put a lot of thought into how we use each of these in terms of how we structure the department and how we, in terms of student learning. So if we look at the USC Greenville approach, what are we doing? Well, every 2 clerkship blocks, we're giving you your learner ratings. This is a tool that's been, as I said before, it's validated, it's appropriate for the kind of teaching that you're doing. In addition, we're not just giving you your ratings, we're also giving you your ratings anchored to your peers. We're showing you your percentile relative to your peers and your percentile relative to the grading scale, which further enhances your ability to interpret that rating. And we're doing that every 2 blocks. The other thing we've done, for example, with our preceptors, we do peer consultation. So we have a retreat with our preceptors every 2 times a year, and we use that approach in looking at each other's evaluations. Again, that'd be a great thing for us to start doing with our faculty and residents. And another thing that I think we should start doing is implementing an OSTI and having that be something that happens especially for our newest learners, our PGY1s, or any new faculty, so that they can get a benchmark on where they are in their teaching and then be able to build from that. So the last thing I really want to leave you with is just an encouragement about what it means to be a good teacher. And this is from Biedler, who was the 1983 U.S. Carnegie Professor of the Year. And this is his advice. If you want to be a good teacher, you have to really want to be a good teacher. And let's be honest, not everyone does. It might be a very low priority for some of us, even though that's the one thing that we start off saying binds us all together. That's what we share in common. The next thing is we have to be willing to take risks. You know what? Sometimes when you do this, you really are exposed and you feel vulnerable. You say, I'm going to take a risk and I'm going to try this with this student. It may not work very well. You may end up getting a rating that you don't like. But without that iterative process of risk-taking, you will never know it's an effective technique. And regardless of what the outcome is, you have to have a positive attitude. And just go in saying, I'm in this for the long haul, and I'll try to do whatever I can. You have to realize that there's never going to be enough time. I hear Dr. Dacus say this all the time. He goes out of his way to make time to go up to labor and delivery or the lounge and find the student, pull them out of whatever they're doing to try and do some teaching with them. And I think this is something those of us who are further along in the spectrum here will think more of, and that's think of teaching as a form of parenting. You know, we expect that our children will one day grow up and we'll have to treat them more like a colleague. And that's exactly the viewpoint we have to have with a learner regardless of where they are in the spectrum. We have to stop thinking about them as students and inferior and start thinking about them as our future colleagues or maybe even the future doctor that's going to take care of us. And then he said, we have to try to give learners confidence. Now, I don't know what kind of backgrounds all of you are from and what genres you're trained in, but that wasn't always something that many places had. In fact, it was all about beating people down and making them understand who's in charge. And that's not an effective way to teach. We have to give people confidence and build them up so that they'll have confidence to pass it on down the road. The last part is try to keep learners themselves off balance. So you have to be willing to challenge them. And sometimes that gets uncomfortable for the learner. And that's a part of that risk-taking, is saying, I'm going to make that learner uncomfortable by asking the why question and really challenging them to think. Because oftentimes we don't know what we don't know. And unless we challenge people, they won't grow from there. So these are my thoughts for you guys on improving clinical teaching. I think we're on a great path in our department. We've really made progress in using effective evidence-based tools to try and improve our teaching, the way we assess teaching, and definitely making it an assessment approach rather than an evaluative approach. But I think that there's a lot of improvement we can still do, and especially in the area of peer consultation and using tools like the OSTI. So there are things that I think we'll continue to work on. I'm happy to entertain any questions.